Hi, everyone. We're going to go ahead and get started now. This is Drew O'Rourke, and I am the Manager of Immunizations and Medical Home Initiatives at the Illinois chapter of the AAP. And we are so happy to have you all here today for this webinar. Before we get started, a few housekeeping things. In order to get your continuing education, I will be sending out a Survey Monkey after the webinar. Please be sure to fill that out within the next week in order to get your certificate. Also, we will be holding questions until the end. If you have any questions, please type them into the questions box, and I will be reading them to Dr. Caskey after her presentation. I'd like to introduce Dr. Caskey. She is an assistant professor of internal medicine and pediatrics at the University of Illinois at Chicago. She is board certified in both pediatrics and internal medicine and is a primary care provider for all ages. Dr. Caskey is a health services researcher, and her research interests include improving adolescent vaccination efforts through examining barriers to vaccine adoption, transition of care for children who age out of the pediatric healthcare setting, and exploring ways to modify preventive health behaviors among young adults. Dr. Caskey has an appointment at UIC School of Public Health in the Division of Maternal Child Health and is a member of the UIC Cancer Center, where she collaborates on efforts to reduce the incidence of cervical cancer. Thank you so much, Dr. Caskey. You can go ahead and get started.
We'll talk a little bit about epidemiology, prevention, and so forth. I will try to leave time at the end for questions. And I do apologize ahead of time. I talk pretty quickly, but that's only because I'm going to get through a lot of information. So I know we have a lot of different people on the call. And so I'm going to try to make this appropriate and applicable to everyone who's listening, but I'm going to go through a few background slides here about the HPV virus for those who are interested in the virology. Nothing you need to memorize or think too much about, but important to know about the human papilloma virus is that there are actually hundreds of types of this virus. And there's both genital and non-genital. The non-genital types are the plantar warts that you get on fingers and feet and so forth. That is not what we're going to talk about today. We're really going to focus on the genital strains. And as you can see there on the slides, I have the type that cause genital warts. The two that are underlined, 6 and 11, cause about 90+% of genital warts. And then below that, I have a number of different types that are high risk, and that really means that these may cause cancer. And I underlined 16 and 18 because those cause about 70 to 75% of cervical cancers in the U.S. And the 4 types that are underlined are in the vaccines that we're going to talk about in a little bit. What's interesting is human papillomaviruses do not change host species. So they remain with humans. They don't jump between species like the flu virus can, where it can jump from a pig to a duck to the human and so forth. HPV really sticks with humans. It does not reorganize itself, so it's actually been a really stable genome for millions of years. It evolved essentially with humans over time. And let's look a little bit at the epidemiology of HPV in the U.S. So it is the most common sexually transmitted infection in the U.S. We have over 6 million new genital HPV infections every year. And nearly 3/4 of those new infections are in 15 to 24-year-olds. So really our adolescent and young adult population bear a large burden of this infection. But what's important to keep in mind, and what this slide shows, is the prevalence of genital HPV among females 14 to 59. So you'll see the ages along at the bottom on the x-axis there. And there's 2 different bars. There's the light gray and the dark gray. The light gray is the low risk, and these are the types that may cause warts. We are not going to focus so much on those today. I really want you to look at the darker gray bars, and this is the high risk or the types that may cause a malignancy. And what's really important to notice is that you'll see it is generally fairly prevalent throughout the life course as a woman ages. So this is cross-sectional data from the U.S. So if we were just to go out today and take a sample of women in the U.S. from all these different age groups, we would see a distribution of genital high-risk HPV similar to this. And it remains high even into the 50s. Now I'm going to compare this to males. So this is the same high-risk strains for men across a similar age distribution. And though I know the 2 charts are not transposed on the same slide, what I can assure you is that these rates are actually higher in men. So over the life course for men up from 18 through 70, the likelihood of having genital HPV, high-risk genital HPV, is higher in men and remains higher throughout the life course. Now let's put this in perspective, because When we talk about sexually transmitted infections, one of the first things that many of us think about are gonorrhea, chlamydia, as the two most common we think about or screen for in our patients. So let me show you the difference. I put on there chlamydia and gonorrhea rates for the same age groups in the U.S. And as you can see, they peak in the adolescent years. We know this for both gonorrhea and chlamydia. They tend to be highest in the teens and early 20s. And as they progress throughout the life course, those rates become nearly negligible. Not zero, but nearly negligible. And look at the difference between that and HPV. HPV is so much more highly prevalent in humans and throughout the life course than gonorrhea and chlamydia or any other sexually transmitted infection. As you could guess, if we put other ones, syphilis, HIV, those would be even much lower than the lines for the gonorrhea and chlamydia, much less prevalent. And so one of the things that I want to suggest today is that one of the worst things we did for this virus in terms of prevention strategies is call it a sexually transmitted infection. Because unfortunately, as soon as we say the term STI, sexually transmitted infection, there's a lot of stigma, negative connotation, perhaps assumptions about behaviors that leap into people's minds. And really, this infection could not be more epidemiologically different than every other STI that we have. So based on this, we know that by age 50, 80% of U.S. women will have acquired at least one genital HPV infection. 80%. It is truly ubiquitous. When 80% of U.S. women are contracting something, this is nearing the rates of, frankly, normal flora, with the exception that it can cause harm. This makes influenza rare. This makes the common cold unlikely. So this is a highly, highly prevalent infection, and that we need to really reframe the way we think about it as not a sexually transmitted infection, but just a ubiquitous virus. Now, luckily, most individuals are not going to develop cancer from HPV, and that's the good news. Over 90% of genital HPV infections will not go on to cause disease. The challenge is that we don't know who will go on to have disease, and that's what makes prevention so important. So transmission, of course, I described this in one of my first slides as a sexually transmitted infection, and sex is a very efficient way to transmit this virus, as it is many viruses. It is a very efficient way, but it is not required. Skin-to-skin contact is what transmits HPV. It does not have to be penetration intercourse. And the virus itself can spread throughout the anogenital region. So someone can contract it vaginally, and it can spread into the anal region as well. So it's very good at spreading along skin surfaces. This is why condoms are probably only about 70% effective in preventing transmission. And that is because, to be blunt, a condom is only covering a portion of the skin that comes in contact during sex. So because this can be transmitted from any skin-to-skin contact, any other skin in the anogenital region that comes in contact can very effectively transmit the virus. And because condoms are not terribly effective, this is also different than all the other sexually transmitted infections we talk about when we think about prevention. Usually our message when we want to prevent an STI is condom, 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 and that message is not applicable to HIV, or not as applicable. There's been a few studies looking at adolescent populations who swear up and down they have not had sex yet. They have not had vaginal intercourse yet. And even if you only want to believe some of them, what's interesting is they found adolescents are testing positive for vaginal HPV prior to sexual intercourse. And so this, again, goes to show that adolescents are probably doing other things, right? There's some experimentation. This could be transmitted from fingers to genitals and so forth. So any skin-to-skin contact can transmit the virus. It does not have to be sex. So the diseases we think about for HPV are the genital warts. And again, I'm not going to get too much into that today. We're really going to focus on the other two. We're really going to focus on the anogenital dysplasias, carcinomas, and then head and neck cancers. So here are the HPV-related cancers for 2014. These are estimated cases by the American Cancer Society in order of prevalence. And as you'll see, oropharyngeal, or what we often call head and neck, is highest, followed by cervical, vaginal and vulvar, anal, and penile. Cervical cancers, as I mentioned earlier, we know that about 99.9% of cervical cancers have been attributed to human papillomavirus now. So for really all intents and purposes, we consider all cervical cancers related to HPV, and the same is true for the vaginal, vulvar, and anal cancers as well. What's often not talked about is the oropharyngeal or the head and neck cancers. And so we're going to go into more detail on those because I think this is a message that unfortunately many providers don't know, but more importantly, certainly the public doesn't know and parents don't know. So if we focus on the head and neck cancers, I show you the distribution by sex. And you can see there's quite a difference in number of cases, males versus females. In fact, males are far more than twice as likely to have head and neck cancer compared to women. What we're also finding is that the incidence of HPV-related head and neck cancers are increasing, particularly among males and particularly among younger males under age 60. So far, as of today, just over 60% of head and neck cancers have been found attributed to HPV-16. This is one of the types that causes many of the cervical cancers as well. And what's important to keep in mind is that this is new research. This is really an area that is just developing. And so I think of where we are with head and neck cancer research today, where we were with cervical cancer about 15, 20 years ago, before we realized the true magnitude of association. So there are many in the field who are experts on head and neck cancer that are speculating in the next decade, we will discover that the majority of head and neck cancers are actually attributable to HPV-16. But as of today, over 60% have tested positive for HPV. We're also seeing an increase in head and neck cancers despite the decrease in tobacco use. So we've made some great strides in the U.S. with decreasing tobacco over the last 30 years. I think many of us would love to see it even lower than it is. But despite that decrease, we're still seeing a consistent increase in head and neck cancers every year. Now, it's very important to know tobacco and excessive alcohol use do remain modifiers in this process, or excuse me, I should call them mediators. So they are risk factors, but many of the HPV-positive cancers are among never smokers and among younger individuals who, if they have smoked or had excessive alcohol intake, haven't been doing it for as long as we typically see for head and neck cancer. So if this trend continues, and there's no reason to suspect it won't, given that it has been going on for over a decade, head and neck HPV-related cancers will exceed the incidence of cervical cancers in about 5 years. And the reason why this is important is that within the next 5 years, give or take, we will likely have more men in the U.S. with HPV-related cancer than women. And this is a message that the public does not know. They have no idea. And it's frankly not their fault. If we think back to those initial ad campaigns with the Gardasil vaccines back in 2006, 2007, it was a very effective advertising campaign, but there was a single message, and it was cervical cancer, cervical cancer, cervical cancer. And though that's an important message and we want to prevent cervical cancer, what's really important is that it's only half the message, and perhaps it's less than half the message. This actually may become a predominantly male disease in the coming years. And this is where, as the health and public health community, we really need to work on educating the public. So everyone wonders, well, how do we get it? For head and neck cancer. The cervical cancer, anal cancers, I think the sexual contact is pretty obvious. And we don't entirely understand, but certainly it has been found that transmission through oral sex is very efficient. So oral sex is likely one of the primary mechanisms for transmission for head and neck. What's interesting is why in younger individuals, and particularly younger men, as I mentioned earlier. And again, we don't know, perhaps different sexual norms, perhaps for oral sex at earlier age or different ages. And then epidemiologically, it's very important to consider that we have decreased other tobacco-related cancers, which might be uncovering what we're finding today with HPV-related head and neck cancers. But the take-home is we don't entirely understand, and this is an area of much-needed research, which is really ongoing. And then the greater prevalence in men. So what's interesting for most sexually transmitted infections, when we think about who's at greater risk of contracting, we worry more about males giving it to females compared to females giving it to males. And the interesting thing is with HPV, this actually flies in the face of that theory. And we see greater prevalence for head and neck HPV in males. And again, not fully understood, but what is understood is that there's a larger HPV burden on the cervix than on the penis. And so that means that it is likely males are more likely to contract oral HPV through oral sex from a woman than a woman is from a man. So this is an interesting, again, an area of a lot of research, but more to come on this, but there's probably a difference in the way it's contracted through oral sex for males versus females. So again, studies have been done trying to determine what is the prevalence of oral HPV. So I showed you those initial slides with the bar graphs that showed the prevalence of genital HPV. And so there's just a few studies done looking at oral HPV. Again, certainly not samples of representative of the whole U.S. population. But what these preliminary studies have found is up to 5% of adolescents and up to 10% of adults have oral HPV. If we were to just go swab the posterior oral pharynx of individuals around the country, we're likely going to see a large percentage that have oral HPV. Now again, just like genital HPV, this does not mean they'll go on to develop any disease, but we don't know who will, and we don't truly understand the prevalence of oral HPV as of yet. And again, more research is ongoing in that area. So briefly, if we look at HPV-related cancers in our great state of Illinois, I've shown the incidence for cervical cancer and oral pharyngeal cancers there out of 100,000. In 2014, it's estimated we'll have 470 new cases of cervical cancer, which actually puts us in the 6th highest incidence in the U.S., and that's an improvement. In 2013, we were 5th highest. So we've been making improvements in Illinois, which is great news, and hopefully will continue over time. But what's really important to consider for all of us that work in this state is that we tend to get really focused on Chicago, Cook County area, and a lot of resources and energy goes into those parts of the state, and myself included. I am fully hold myself responsible for focusing a lot on Cook County when I'm doing my work around vaccines and HPV. So one of the best things I did a few months ago is have to prepare a talk for a group of physicians down in southern part of the state, and I realized, oh my gosh, I have not gone to look at where their incidence rates are, and I assume them to be fairly similar to Cook County. And what I want to share with you is some data from around our state. So St. Clair County, yes, it's actually very similar, not too different than Cook County. But look what happens if we look at Wabash County, their head and neck cancer. Huge difference compared to Cook County, much, much higher. Gallatin County, same. And look at cervical cancer in Hamilton County. And I share this with you because, again, I think when we think about health disparities and inequities within our healthcare system, we have to remember it is not just about race, ethnicity, income, that place matters. And we have large populations throughout our state that are in areas with much higher prevalence than we have in Cook County. And this is probably multifactorial, access to care, access to screening. You know, we could all come up with a number of reasons why this might be. But I share this because this was a stark reminder to me that we have to consider place and that there are huge disparities within our state, all throughout our state. Unfortunately, I feel like I have to have a moment of discussing HPV and sex. So I will have one slide on this to assure you all and allay any concerns that vaccination against HPV does not affect sexual behavior. If there's anyone on the webinar like me who takes care of a lot of adolescents, we did not need research to prove this to us. However, I think because of some of the sensationalizing by the media and a few folks that got very concerned about this link between if we vaccinate youth against a sexually transmitted infection, will that give them license to have sex with the first person they see walking down the street? And first of all, let's give our young people a little credit. But there's now been, I believe, 5 studies done, mostly looking at women, but they've looked at all age groups, younger adolescents, middle adolescents, young adults, college age, et cetera. And all of them have compared a vaccinated population to an unvaccinated population. And they have found no differences in age of sexual debut, number of sexual partners, pregnancy rates, nor chlamydia rates. So I hope we can stop wasting our valuable research dollars on this, and I can assure you vaccinating against HPV does not affect sexual behavior. and we can allay any parental concerns on that front. So let me talk about the vaccines really briefly here. HPV-4, this is the quadrivalent, that's the top one, Gardasil by Merck. The bivalent Cervarix by GlaxoSmithKline, I'll talk about second. So this is indicated for females 9 through 26. Prevention of types 6 and 11, which again, those are the kinds that cause 90% of warts, and 16 and 18, which cause 70 to 75% of cervical cancers. I will not read through those FDA indications. You can see them on the slide. What's important to keep in mind is that you will not see head and neck cancers in the FDA indication for any of the HPV vaccines. And there's important reasons for that. Head and neck cancers were not studied and will not be studied in the manufacturer clinical trials because there is no precancerous identifier for head and neck cancer. So we're very fortunate in cervical cancer that there are precancerous markers that we can identify and treat. And that is not the case for head and neck cancer. So as you could imagine, you'd have to follow cohorts for decades to truly appreciate differences in head and neck cancer. So that will never be a FDA indication for the vaccine. However, as I mentioned earlier, there's very important research trying to better understand HPV and head and neck cancer. And so it will likely be, for healthcare providers, one of the primary concerns when we think about preventing HPV. Indicated for males, 9 through 26, so same ages as females, prevention of the same 4 strains, and again, you'll see the indications listed. I showed this just very briefly. It's a busy slide. Don't worry about a lot of the details. But I do a lot of research with a number of different vaccines. And so I think I'm the only person in America that actually looked at that little package insert in the vaccine box. You know how when we all get our prescriptions, it's that little piece of tissue paper that's like folded into origami and shoved at the bottom of the prescription. So I actually looked at it. And what was really interesting to me is, and impressive, is the efficacy of the vaccine. Now, keep in mind, this was clinical trials, and this was only in, I think, the first 2 or 3 years of the clinical trial. But nonetheless, you see pretty amazing efficacy. Let's see, 94% or above for all of the different indications listed on the left-hand side there. And to put it in perspective, if we have 70% efficacy for influenza vaccine, we consider it a great year. We think that is phenomenal because we really never get much better than about 70%, maybe 75% effectiveness for an influenza vaccine. Compare that to Gardasil, which shows incredible effectiveness in this early period against these diseases. Now, all of these cohorts are, of course, being studied for a long time. The longest studied cohort out of Scandinavia is about 9 to 9.5 years out. And so far, the data looks excellent in terms of maintaining that efficacy. But of course, for all of us, what we really care about is not just 9 to 10 years, but we care about 19, 20, 40 years out. And time will tell. But so far, the efficacy is holding very strong. The bivalent Cervarix by GlaxoSmithKline was licensed shortly thereafter. This is indicated only for females, 10 to 25, because it only includes types 16 and 18, and was only studied for cervical cancer. So again, Cervarix bivalent, 16 and 18, but for females only. So the Advisory Committee on Immunization Practices, and this is the committee that's part of the CDC that makes all of our immunization recommendations. They come out with all those charts for kids as to how many MMRs and varicella and so forth. And they have made formal recommendations for HPV vaccination. All males, and all females, universal recommendation, with a target age of 11 to 12 years, maybe initiated as young as 9. And for those who are not vaccinated by age 12, we recommend catch-up for females up through age 26, and for males either to 21 or to 26. The difference for males, so why is it different? What is high risk? High risk is defined as anyone who has HIV or another disorder that might be compromising the immune system, or men who have sex with men. The reason why there's a difference, if you think back to one of those early slides I showed you with the bars that showed prevalence of genital HPV, males have a higher prevalence. And by age 21, the proportion of males who have likely had genital HPV is much greater than for females, or is greater, it's not a lot greater, it's greater than for females. And keep in mind, vaccines prevent disease, they do not treat. All vaccines. Vaccines are prevention, not treatment. So if you look at a cost-benefit ratio of vaccinating all 21 to 26-year-old men in the country, against HPV. And then you also have to consider that many of them already have been infected and so will go on to get disease regardless of vaccination. That cost-benefit ratio changes. The vaccine is still very effective and very safe, but it changes. It is more costly because these males are more likely to have already been exposed. And that's the difference there. And if we have time again, I'm happy to go into more detail there. Recommend is the same language used by the ACIP for all the other vaccines you are using. For MMR, varicella, DTaP, Tdap, all of this. It's the same strength of a recommendation. I think there was some confusion in the beginning that this was almost like a light recommendation, wasn't the same. It is exactly the same strength recommendation as all the other vaccines. So we should offer HPV to all adolescents and young adults within the age range, regardless of sexual history. We don't care who she's had sex with. We don't care how many partners he's had. It doesn't matter. Does not matter if there's been a history of an abnormal PAP, and it doesn't matter if there's a history of an HPV positive abnormal PAP. So if you send it for reflex testing after thin PrEP, after doing a PAP, and it came back high-risk HPV, that doesn't matter. Sexual orientation doesn't matter with the exception of course, that high-risk population for males after 21. And there's only two things we need to think about when considering HPV vaccine. Age, again, 9 through 26 is the FDA-approved age range. And second, for females, might she be pregnant? To be clear, you do not have to do a pregnancy test. You simply ask her if there's a chance she might be pregnant. Of course, if she says there is, you should do a pregnancy test regardless of the vaccine. But technically, the vaccine is not approved for pregnant women. Now, as you might suspect, in those clinical trials done by the manufacturers, they had large numbers of women in the initial trials. And though, of course, I'm sure for entry into the trial, they had to assure researchers that they were not interested in getting pregnant and were on birth control. But as you can imagine, life happens. So they actually had a few women get pregnant during the Gardasil trial and then followed them very carefully and very closely and followed their children as well. And there has been no documented adverse event to mother or child by getting the vaccine during pregnancy. Nonetheless, because that's technically would be an off-label use, and probably I think we'd all err on the side of caution when pregnancy is involved. That is the only other question you need to ask if it is someone that is sexually active, a female sexually active. All right, so how are we doing? Well, we're not doing that great. This is the most recent data that came out over the summer from the CDC National Immunization Survey. And I put as a comparison group, I put Tdap and meningococcal, our other two recommended, universally recommended adolescent vaccines. And then you can see females and males for HPV. The orange bars, the first orange bar is having one or more doses of HPV, so dose initiation. And then the second orange bar is series dose completion. So as a reminder, it's a 3-dose series given over 6 months, at times 0, 2 months, and 6 months. The timing interval is exactly the same that we use for hepatitis B, if that's helpful for folks to remember. So, and then that final blue bar, as you can see, that just tells you the percent of those who initiate who complete it. So the good news is, of those that start the vaccine series, about 70% completed. But the challenge is that that still is only about 37% of females across the U.S. And this is 11 through 17-year-olds. And if we look at males, it's less than, it's about 12% of males have completed the HPV series. So we have a lot of room for improvement here. What's also important is that these are relatively newer vaccines, certainly, but we're seeing a decline in the rate of uptake. So if you look at this slide, Tdap and meningococcal are those top two lines, and then you'll see HPV initiation females, completion females, initiation males, and completion males. And the concern for females really is that the slope has declined, that we're not seeing the steady increase we want to see that is being seen with Tdap and meningococcal. Now, importantly, those two vaccines are driven a lot by school mandates. Here in the state of Illinois, they are as well. But nonetheless, if adolescents are getting those vaccines, it means there was an opportunity to vaccinate them, and we had a missed opportunity for HPV, which is a really important consideration when we think about the levels we want to reach for herd immunity. And if we compare ourselves to our neighbors across the globe, there's quite a difference. We look positively developing world. I mean, this is just terrible. Our rates are so much lower compared to Rwanda, UK, our neighbors to the north in Canada, and so forth. And what's interesting is most of these countries have, almost all of them actually, have used alternate mechanisms for vaccination. They don't use their traditional healthcare setting as we do in the U.S. Many of them have used schools for vaccinating. So Rwanda, Australia, Canada do a lot of the administration of adolescent vaccines in the schools because that is a great place to capture them en masse. So now that we've had 7, almost 8 years in the U.S., what do we see? We've had over 60 million doses of HPV vaccine distributed in the U.S. We have had over 350 million distributed worldwide. That matters because when we want to think about safety and efficacy, we need a lot of doses distributed. And I think we are there, particularly worldwide. The doses in the U.S., as I mentioned earlier, could be better, but worldwide we've had a lot of doses distributed and a lot of opportunities for studying adverse outcomes. And the good news there is that the most common adverse events are very mild, as they are for almost all vaccines. And the most common would be a sore arm or myalgia. And having just received my flu shot the other day, I can assure you any time a needle is entering your deltoid, a sore arm or myalgia is entirely likely. And so this is no different than all other vaccines. There's been no patterns to suggest any serious adverse events caused by the HPV vaccine. No patterns. A serious adverse event is defined as an adverse event that requires medical attention. And so there's been no patterns to suggest that. So just as safe as all the other vaccines we use regularly. Let me just go to this slide. So there's a number of organizations and manufacturers that follow the vaccines. So the manufacturers, both Merck and GlaxoSmithKline, are required to do post-marketing safety surveillance, and they've been aggressively doing that, as well as the CDC runs Vaccine Safety Data Link, which connects to a number of large health maintenance organizations around the country, including Kaiser, which can provide very good, very comprehensive data about vaccination rates, adverse events, and so forth. And all 3 of those have found no statistically significant increase in any risk for adverse outcomes for the HPV vaccine, both Gardasil and Cervarix. Very briefly, there was also some surveillance done looking at autoimmune adverse events. Unfortunately, as we know, many autoimmune diseases tend to start to develop during adolescence, and so there was concern early on, were we seeing an increase in these autoimmune diseases, or were they simply rearing their ugly heads around the time that a youth might be vaccinated, just like we encountered with the autism and MMR. And again, that's what was found, is there's absolutely no increase in autoimmune diseases in individuals who are vaccinated versus not. So clinical outcomes. For better or for worse, if there's one good thing about worse, that is that you can study them very quickly. They happen very rapidly. So one of the first things that we were able to study here in the U.S., and again, this is still relatively early, is looking at the change in genital warts among females in those individuals that were initially vaccinated in some of the first few years after FDA approval. And already you start to see a decline, particularly in the group that would have been vaccinated. But I think the more interesting data is from Australia, because this is a country where they have much higher vaccination rates, and so they have a much larger cohort to study. So as you saw in one of those earlier slides, if over 80% of school-age girls are fully vaccinated in Australia, keep in mind they now are vaccinating those males as well, but they started with females because the licensure was first for females. They've already begun to see decline in high-grade cervical lesions in women under 18 in the first 3 years. So that's pretty impressive, and much sooner than most of us would have expected. For cervical cancers, we were expecting more, approximately a decade to really notice appreciable changes, but they have already documented decrease in high-grade cervical lesions in those under 18. What's really interesting is so they've already shown their herd immunity. So among the vaccine-eligible females, they had a 93% decline in genital warts. Very impressive. So these are the females that got vaccinated or were eligible to get vaccinated. 93% decline, so it was working. They then studied those females' unvaccinated male partners, and again, this was before they started their campaign of vaccinating males, and they found 82% decline in unvaccinated males. So again, evidence of herd immunity. The disease went down in the females, their unvaccinated partners were protected. This group took it one step further that's been recently studied and published, but I apologize, it's not in this slide. They also looked at a smaller cohort of unvaccinated female partners of those unvaccinated males. So basically, the other women partners of the males that were not vaccinated, and saw a decline in warts for them too. So we basically have second-degree herd immunity, where there's herd immunity to the initial exposed group and to the secondarily exposed group, which is really interesting. And that warts, again, because they happen so rapidly, can be studied much faster. Most of us really are interested in the rates of cancers after vaccination, and it will take a number of years to fully appreciate that, but there's some initial data coming, and this just shows that decrease in genital warts. All right, so in our last few minutes, let's talk a little bit about vaccinating adolescents. And as many of you on the webinar can appreciate, there's many challenges to vaccinating this age group, and I'm not going to go through all of them today, but I'm going to talk for a moment about access, because I think this is really important when we think about that our models for vaccination, but also the need for herd immunity. So this is data from Illinois, this is from Michigan, and this is a Medicaid-enrolled adolescent population. But keep in mind, I've looked at similar data for commercially insured adolescents, and it's virtually identical. And what this group found that is in a 2-year period, less than 50% of 11 to 18-year-olds had a health maintenance visit in a 2-year period. And whether you want to call it health maintenance, primary care, preventive care, well, adolescent, use your term. What they meant is essentially a primary care visit in a 2-year period. And this is problematic because in the model of pediatric care in the U.S., whether you're going to a pediatrician, family practitioner, nurse practitioner, we give vaccines in the setting of our well child care, our health maintenance visits, preventive care visits. We often do not think as strongly about vaccination in other types of healthcare visits. And this is important because if we use that model for vaccination, at best we'll get just under 50% of adolescents, and that's if everything's perfect, and it never is. So our model for pediatric vaccination does not serve adolescents well. What's interesting, though, is the same group, they looked at if those youth were interfacing with the healthcare system at all. And in fact, they are. So if you look at this, this is problem-focused visits. This could have been to the primary care provider, this could have been to an urgent care ER and so forth, but any problem-focused visit. And in fact, almost 80% consistently across the age groups was having at least one problem-focused visit in a 2-year period. This is, again, a 2-year period. So these youth are interfacing with the healthcare system. They are not getting primary care within the healthcare system. So when we think about where we tend to vaccinate and how to best administer vaccines, we need to really consider a more of adult model for adolescent vaccines. So capturing missed opportunities, I know we talk about this all the time for the infants and toddlers as well, but it's probably more salient for adolescents because they come in so much less often. You know, those infants, luckily we've seen so frequently that even if there is a slight delay in vaccines, we can often catch them up within a 6 to 12-month period. And that's not going to be the case for adolescents. So if we can try to capture them on the non-primary care visits, coming in with a sprained ankle after football practice absolutely does not preclude you from getting a vaccine. And so if we can try to really improve capturing youth at those visits. Standing immunization orders have shown to be very successful for adult vaccines, particularly pneumococcal and influenza. And we see this in the literature for adult inpatient and outpatient vaccines. If we give nurses, medical assistants, pharmacists, whomever is the appropriate person within your clinical setting, if we give them carte blanche to screen and administer vaccines, they're more likely to happen. Because when they come in to see the provider, we get focused on the sprained ankle, the this, the that, the anticipatory guidance, and all of these other important things, and sometimes we miss the vaccines. So that has been shown to be very effective for adult vaccines and may work for HPV. And I think probably the most important is normalizing HPV vaccine. So we know these adolescents are getting Tdap and meningococcal, and they're getting them somewhere. And there's probably no reason they could not have gotten HPV at those opportunities as well. And so there's something happening that is preventing HPV vaccination as widely as our other adolescent vaccines. And that's something where I think we need to get away from talking about sexually transmitted infections. We have to get away from the stigma and really normalize this vaccine. So let's talk a little bit about that. One of the things I've come to appreciate in the past few years in my research, but also in being introspective about my own clinical practice, is that I think for HPV vaccines, providers sometimes are part of the problem. And I'm going to share with you exactly what I mean. We really don't often present the vaccine in the most appropriate light. And to be clear, it's very well-intentioned. I think many of us are very excited and we want to talk to parents about it and explain to them all these potential benefits. And oh my goodness, we have a vaccine that could prevent cancer. You know, how wonderful. However, the way in which this has happened has not always been terribly effective. So let's go through very quickly in our last few minutes here before questions, a few key concepts. Sex during adolescence is for other people's kids, right? And anyone who's on the line who has an adolescent probably resonates with this statement. Parents don't want to think about their kids having sex. They particularly don't want to think about their 11-year-old having sex. As I tell my colleagues, you know, the parent wants to think about the 11-year-old having sex as much as that 11-year-old wants to think about the parent having sex, right? Nobody wants to think about it. We're not talking about a 17-year-old, 18-year-old. We're talking about a youth that, in the eyes of the parent, is still prepubescent. All right, so that's really important. Is that we don't want to start the conversation with something that makes a parent uneasy and uncomfortable and so forth. The second consideration is immunizations 101. Most parents have no idea how vaccines work. They do not appreciate the fact that vaccines prevent disease, they do not treat. And you can only prevent if you are vaccinated prior to exposure. And so that's why targeting 11 to 12-year-olds is so critical, because we really want to capture adolescents prior to exposure, keeping in mind you don't have to have sex to get exposed. So prior to any sort of, you know, experimentation and et cetera that may happen in those middle adolescent years, we really want to get kids vaccinated prior to that. So what many parents will say is, oh, well, she's nowhere near sex. You know, we'll come back for that when she's closer to having sex. And certainly, I think we all know the parent's likely the last person who's going to be informed when she's ready to have sex. And so we can't just wait for that minute, because that minute will pass and then we'll lose the opportunity for full prevention. So we have to vaccinate prior to exposure. And then for many parents, this vaccine is simply new and they have questions. So I do some vaccine work in the Chicago Public Schools, and over the years between clinical work and in the schools, I've talked to hundreds of parents about vaccines in general, and including HPV. And what I've found is that the majority of parents have very, very appropriate questions, and in fact, the media has sold them short, and the sort of hype and ridiculous stories we hear in the media about parents freaking out about this vaccine is really probably a very small number of parents. Most of the questions are, what does it do, who's it for, is it safe? And if you think about it, those are completely rational questions. They are exactly the questions I would want a parent to ask if I'm proposing something that is new to them, if I was prescribing a medication, suggesting a radiologic procedure, you name it. This is exactly what good parents do, right? We say, what is that? Who is it? Does my child actually need it? And is it safe? And so I think if we also keep those questions in mind when we are approaching this vaccine, it helps, because we don't have to launch into other things that may not be the primary concern for most parents. So let me show you a quote from a resident I worked with a little while ago about how he suggested the vaccine to a parent of a adolescent. And again, I want to be clear, this was a very well-intentioned description, but it went something like this, and this may sound somewhat familiar to you. HPV stands for human papillomavirus and causes genital warts and cervical cancer. It's a sexually transmitted disease. Many kids become sexually active by age 14. Do you want this vaccine for your 11-year-old? The problem with this messaging is, even though it certainly could all be true, it gives parents this reaction, right? Because what we started this conversation out in looking at this beautiful little blonde, blue-eyed 11-year-old girl is we started talking about genital warts, cervical cancer, and sex. And this is a horrible introduction to a parent of an 11-year-old. It's a horrible introduction. It sets the stage in a way that makes everyone uncomfortable. So what we've started is the less is more approach, and this goes something like this. Today your son is due for 3 routine vaccines, which include meningitis, Tdap, which is tetanus, diphtheria, and whooping cough, and HPV, which stands for human papillomavirus. Someone will be right in to administer those vaccines, and I look forward to seeing you next year. And then, of course, we skedaddle to the door and run out before the needles come in. The difference, this is not about withholding information. This is not about avoiding full disclosure. This is about treating HPV vaccine the same way that I treat varicella, MMR, Tdap, meningococcal. I don't go into a long diatribe with a parent of a 4-year-old regarding varicella vaccination, unless, of course, the parent wants to, but I don't initiate it. I finish the visit, say, okay, these are the vaccines to do, we'll see you later. And I think many on the phone feel the same way. That's what most of us do. We don't sit and make a fuss at 6 months, at 12 months, at 18 months about those vaccines. We're acculturated to them, as are families. We simply know that vaccines are part of these visits as well as other important aspects of care, and we simply recommend the vaccines. And so what we're now really encouraging providers and clinics to do is approach it the same way you do the other vaccines. Don't make this one different. Because what happens is as soon as you sit down and say, okay, 11-year-old, great, we're going to get you Tdap, we're going to get you meningococcal, let's talk about HPV, and you launch into a story about HPV, that parent is left with, wait a minute, you didn't just go into a story about Tdap, and you didn't go into a story about meningococcal vaccine. What is different about this vaccine? And I think by doing that, even though it's been incredibly well-intentioned by all of us, we kind of create fear and concern and skepticism where it was not before. And we don't give parents something to worry about that they weren't worried about coming in your door. Now, if questions do arise, we absolutely should engage in a conversation. And we are really working to frame it as more about cancer, not about sex. This virus is too ubiquitous to care about how it's transmitted. When 80% of U.S. women will have had a genital infection, I frankly don't care how it's transmitted. We talk about what we want to prevent and what we care about. We talk about cancer and the opportunity to reduce a cancer experience for your son or for your daughter. And I think if we paint that picture for parents, it is a much more digestible message and just as accurate, just as true. So I'm going to finish with all of our recommendation matters most. We know that parents and families listen to their providers. They trust us. They trust their doctors, nurses, nurse practitioners, etc. And so do your family members, friends, neighbors, community members. And the way we message this vaccine really matters most. So I am now going to take questions. Drew, if you want to let me know if there's any questions typed in, and I can pull that up on my screen as well.
Okay, we've had a few come in. Do you want to read them aloud, or I can? Did you see them?
Go ahead, please.
Okay.
Go ahead.
First question is, if HPV-related cancers are so prevalent, especially among men, why is Gardasil only recommended for 9 to 26-year-olds? Shouldn't all ages be vaccinated?
Yeah, that's an excellent question. So, right, what about after 26? Let's be honest, it's not like people are not having sex, and in fact, we know the largest percentage of the sexually active population, of course, are adults in the U.S. So there is research on Gardasil through age 45, which shows that it is just as safe and nearly as effective. So instead of being 99.9% effective, it's something like 92 point something effective. I'm making up those numbers, but just to give you a gist. And the reason why it's not quite as perfectly effective is because, again, exposure is more likely to have already happened, right? So it will not do anything about HPV that's already transmitted, but it will prevent new. So this was presented to the FDA by Merck, and the FDA did not extend the age range because of the cost-benefit ratio. So because so many people in that age bracket over 26 are likely to have already been exposed, we will be paying for both vaccination and paying for the treatment of any diseases for strains they already had, which changes that cost-benefit ratio. Now, I think there's going to be further discussion on that, so I don't think that that's the end of the story. We'll see what happens over time as more and more data is collected on these older adults. What I will tell you is I vaccinated a number of adults. I've vaccinated a number of medical residents, in fact, and I share with them the safety data and the efficacy data. And keep in mind, too, the efficacy data in older adults is still better than most vaccines are in children. Now, the important thing, though, is the cost. Because it would be an off-label use, insurance companies will not cover it over age 26. And so individuals who are interested in getting vaccinated have to be willing and able to afford the vaccine, which retails at somewhere between $130 and $165 per dose, and that it's a 3-dose series. So that's the long answer to a short question. I think we'll see more on this in the horizon, but it is something I definitely have administered to adults. You just have to approach it differently.
Great, thank you. And we have one more question. If there was an HIV vaccine, how would you predict the acceptance of it compared to the HPV vaccine?
Yeah, in many ways, you know, people are wondering if the HPV is kind of paving the way for our HIV vaccine. And it might be. It's, you know, getting a lot of these discussions and such on the table. Now, I think, so to be fully honest, I think we will have a huge problem if and when we have a successful HIV vaccine, and I think most of us hope we do someday. If and when that happens, I think this will be a huge challenge because it is such a stigmatized infection. So maybe some of the work we're doing with HPV will help. One of the big differences, though, is really very different transmission and epidemiology. So HIV thankfully remains low prevalence in the U.S., thankfully, and it is not nearly as transmissible. So if we look at discordant couples, if we look at someone who has HPV, having sex or any intimacy with someone who doesn't, that person who doesn't have HPV is highly likely to contract it very quickly. And that's not the case for HIV. We know it doesn't happen immediately, and it sometimes can take time. So it is, it's tough because they are different in many ways, but perhaps it's better that this one came first because it allows some discussion surrounding sex and prevention of infections that could be transmitted via sex.
Great, thank you. And we have time for one last question. Do you have any information on the 9-valent vaccine?
I don't. I know it's being studied. It's certainly in the works by Merck. But admittedly, I don't have a lot of information. I have not heard any preliminary results about efficacy or so forth. I am speculating, and this is sheer speculation, that it will be probably as good, if not better certainly, than the current the quadrivalent, the Gardasil. But this is sheer speculation. I think we'll know more probably in about 24 months.
Great. Thank you so much. And thank you, everyone, for joining today. This was a great webinar. Again, I will be emailing out a survey to follow up. And once you complete that, you will receive your certificate. Thank you again, Dr. Caskey.
And no problem. And if any further questions come up, you're welcome to forward them to me, Drew, and I can get back to folks.
Okay, great. Thank you so much. Have a good afternoon, everyone.
All right, take care. Bye-bye.
Bye.